My name is Dr. Fallon Shapiro. If you don't know me, I did a short stint to work under Dr. Cherney for a little bit. And then I decided to move to home hospice and Yomishpu. So I work around in the South for now. So Adir asked me last week if I wanted to do journal club, and I said sure, because that's one thing I do miss from the hospital. By the way, is English okay for everybody? Okay. So we chose this article that came out in November of last year, just a few days ago. It's on Ritalin or methylphenidate as a need for fatigue in patients with advanced cancer, a prospective double-blind and placebo-controlled study that was done in Denmark. Okay. So just a little bit on cancer-related fatigue. It's defined as a distressing, persistent, subjective sense of physical, emotional, or cognitive tiredness or exhaustion related to cancer or cancer treatment that is not proportional to recent activity and interferes with usual functioning. And this is a very technical definition, but in general, we know what this is. Most of us have seen it. Up to 90% of the patients have it. And I do want to emphasize here that it says related to cancer or the cancer treatment, because you'll see later in the study why that's interesting to me. And then it usually has the most negative impact on their daily life, much more in quality of life, much more than nausea, depression, and even pain. Okay. So first, in general, fatigue, we look at underlying causes. Most of us have some sort of a Pinamite background, and so you want to make sure you haven't forgotten that. So you think about anemia, hypothyroidism, electrolyte imbalances, even hypoxia I've seen. And you try to work on these symptoms, these causes. If these are not helping, which usually is the case, after you've treated them, then we start looking at medications. And of those, the most ones that have been most helpful have been psychostimulants, especially methylphenidate, okay? And in the paper, they review all the studies that have already been done on methylphenidate, and they're mixed results, and so that's why they decided to do this study. So just a review of the study participants. They were all recruited from the Department of Palliative Care Medicine at the University of Copenhagen Hospital in Denmark. This included inpatient, outpatient, and home care patients. But it's only one study, like one center, which also makes a weakness in this study. The inclusion criteria were advanced cancer and pronounced symptoms for which palliative care could only be offered. Exclusion criteria included anyone who had already been given psychostimulants during the last 2 weeks, if they had ever had allergic reactions, if they had a history of psychosis, if they had uncontrolled hypertension, arrhythmias, or chest pain, or used monoamine oxidase inhibitors, any pregnancy or breastfeeding, obviously untreated anemia, which they count as less than 10, which I thought was pretty high cutoff, because a lot of patients can be around 8 or 9 and they're fine. And then hypercalcemia and thyroid toxicosis. Again, those are those cases where you want to make sure that they're not causing their tiredness. And then they also excluded ongoing radiotherapy and chemotherapy, which I thought was interesting because it's also a cause of weakness and fatigue in patients, and so why they were excluded. And then brain metastases and glaucoma, I'm guessing because of the intracranial pressure that it caused. But still, we have a lot of patients with that as well. So that was a little bit, those are going to exclude a lot of the patients that I see day to day, which I'll probably still try it, but just with more caution. And then because of the patient's heavy symptom load, there was no restriction on the use of steroids or opioids. Okay, the study design was interesting. They enrolled from March 1999 to June 2003, about 4 years. It was a prospective, controlled, double-blind, and paired design, and the patient was their own control. So what they did is they were given a box with 10 placebos and 10 methylphenidate tabs, which I gave you a picture of kind of like what I imagined what they did. They were each individually wrapped in plastic bags, and they were numbered 1 through 20. And then they were put into blocks of 4, so that each block had 2 active and 2 placebo pills. And those were then randomly arranged, okay? So you see I put like block 1, 2, 3, 4, 5, and I imagine they did a much better job at randomized than what I did with the pictures. And then they essentially gave them to the patients and told them to use them as needed. okay? The pharmacist is the one who made the tablet randomization, and so the patients, the physicians, and the nurses were all blinded, okay? Okay, then they were instructed by taking the tablets in the predetermined order, okay, of the blocks, and they were allowed to take up to 3 tablets a day with a minimum of 3 hours between them. So that would be, for example, taking it 9 in the morning, then 12, and then 3 in the afternoon. They were not supposed to take it after 5 at night so that they wouldn't be kept from sleeping. And they took it just for 1 week. We're given the study just for 1 week, 5 days. And anyone who took at least 3 tablets during the study period was kept because they for sure took at least one active and 1 placebo.
So, Fallon, sorry, these are 10 milligram tablets?
Yeah, they're 10 milligrams. Okay.
Yeah.
Hang on, let me just quiet my phone. Okay. All right. And then each patient was to fill out a questionnaire before taking the tablet, and again at 2 hours and 5 hours. And those questionnaires were based on your ESAS that has the 9 VAS systems. Most of us are familiar with that, including the pain, activity, nausea, depression, anxiety, drowsiness, appetite, sensation of well-being, and shortness of breath. On top of that, they also added tiredness and concentration, because that's specifically what this medication is used for. So they wanted to see if it did. And then they also, just for characterization of the patients, they used the European Research and Treatment of Cancer Life Core Questionnaire and the multidimensional fatigue inventory, just to make sure that the patients were on the same baseline. Okay, so only 38 patients were enrolled over the 4 years, of which 8 were lost to follow-up and then 2 were excluded. And so in the end, they had 28 patients. Okay, the ages ranged from 40 to 84 years. Most of them were women. And then I didn't put them here, but tables 2 and 3 show that their baseline scores showed that they had a very heavy burden of reduced activity and fatigue, and that there was no difference between those of all the scores with the baseline scores, those who were on methylphenidate or placebo. So their baselines were the same.
So not all of the patients were getting both methylphenidate and placebo.
Right.
So this is not a 2-arm study. This is like multiple N of 1 studies. Each patient
Right.
is in control. Yeah,
exactly. They were their own control. Okay, so this table 4 shows their changes in their symptoms at the 2-hour mark. Okay, and so the MP you see on the first column, the MP is the methylphenidate and the PL is the placebo. Okay, and you can go one by one and see how the numbers. But if you look, so essentially a negative value, it means it reflects a larger decrease in symptom intensity. And for most of them, the methylphenidate was had a higher efficacy than the placebo. So if you look at tiredness and fatigue, which was what they were most importantly trying to look at, that had the -20 for the methylphenidate and the -8 for the placebo. So placebo actually did have, we always wonder about placebo. Placebo does have an effect. And then the mean difference obviously tells you how much the difference was, and then you have the p-values on the far to show what was significant. And so things that we would imagine it would be helpful for, like tiredness, concentration, drowsiness, that was where we saw the biggest change. Interestingly, it increased pain, which I thought was interesting.
I mean, when you look at so many different outcomes, you need to adjust for multiplicity. Because when you're looking at so many different outcomes, some of the differences can become random.
Okay.
Okay. So, while I clearly agree that there are the 2 outstanding things that seem to show that there's improvement are drowsiness and tiredness and fatigue. When you do a salad of outcomes, okay, I mean there are adjustment techniques that the statisticians should be applied for multiplicity, and it is not clear that they have done that.
Yeah, no, they don't talk about that in the study.
Sorry, just to clarify, I'm not sure I understood completely. The mean change is an ESAS score or an ESAS plus the additional scales?
It's the
Because I mean, the 12 doesn't make sense in ESAS or 11.
no, I agree with you. It says here ESAS +2, but in the actual paper they just talk about ESAS scales. So I'm not sure why on the title of this they put it there. Maybe they're just talking about the two they added. I guess because they don't show them separated, so I guess they did add them. But you're right, it wouldn't make sense. And then the next one just showed it at 5 hours. Which again, the biggest improvement was in the tiredness and the fatigue and the drowsiness. And so just regarding tiredness, the primary effect parameter, which was your mean change decrease, that the methylphenidate after 2 and 5 hours showed 20 and 17 respectively, whereas the same for placebo was 8 and 5. When you compare the differences, the decrease in methylphenidate was significantly larger than the placebo, both of them with p-values respectively. So again, that was their point that they wanted to make, that it was better for their primary goal of showing that it was better for tiredness and fatigue, but it also did show helping with drowsiness and activity. Okay, those were also.
Did they titrate the dose or did they start directly with 10 milligrams?
No, they just did 10. There was no titration, just 10 random pills. Yeah, I also thought that was interesting because if it worked well, you could definitely increase it.
Okay, thanks.
Mm-hmm. That's just the graph that shows the placebo at 2 and 5 hours, how they were significant with their p-values. Okay. Okay. As far as weaknesses, again, it was a single institute. The follow-up was not complete. They had only 28 that were actually enrolled of the 38, and the follow-up was short. Again, they excluded, excuse me, the typo there, excluded patients going radiotherapy and chemotherapy, which is a lot of my patients and y'all's patients too. So I feel like it's not helpful 100%. And then again, they kind of brush over the potential adverse side effects. And they say, for example, just vertigo and leg swelling, but I know lots of people who take this for not cancer, for actual concentration. It has a lot of side effects. They have problems with sleeping, decreased appetite, anxiety, weight loss, psychosis, and all of these are symptoms that would not be helpful in our patients. And so to always, take it with a grain of salt of whether it's helping them. And then again, always be wary of serotonin syndrome if they're also taking other medications. And so for me, I felt like, the study indicates that 10 milligrams can be administered to effectively reduce tiredness and drowsiness after 2 and 5 hours. And maybe for a patient that's their main, there are a few patients that I thought of that is their main problem. Everything else is fine. They just are so tired all the time. So I do want to try it in some of my patients, but again, everything will be under a very, with a finger on the dofek, as we say, espala dofek, to make sure that I'm not hurting them. So questions?
What was the mean dose of Vitalin per day?
Theoretically, if they took all of the 3 tabs and they took both, they essentially got, if you go back here, they got 4 tabs.
Yeah.
Okay. And each tab there were 2 placebos and 2. And so if they got it where they took 3 and 2 were the actual methylphenidate, then they took 20 milligrams. So that was the highest dose that they were getting. But again, they were taking them 3 hours apart. So you could argue that it had already worn off or partially worn off. And so I'm not sure how much, I think 10 milligrams to say safely they got.
And so can you just discuss how they put that in the context of their literature review? Because this is a subject which has had meta-analyses performed beforehand. And interestingly, this is a study that was done like 17 years ago, and they're only publishing it now, and that's also quite.
Yeah, so they did comment about that. Apparently, the main author who started the study wasn't going to publish it. And then as she was sort of closing up shop, it sounds like she was retiring or moving departments or something, the data was passed down and somebody found it and said, why are we not, this is great, let's do it. And I think it was sort of like easy fruit. That's the way I read it. It was like easy fruit for someone to write a paper on because the data was all there and it looked good. And so she just let them sort of take it. That's how it looks like to me when I read it. But they say it much more politically polite there.
Wonder why it was so difficult for them to recruit patients. Only 38 patients, really? I mean,
I'm guessing because they excluded people with chemotherapy, because I mean, most oncologists who are doing studies, once they're in hospice mode, then they're no longer seeing their oncologist quite so regularly. And so maybe they just didn't have access to so many. I'm guessing. I think the exclusion criteria was very strict. Where did it go? Here. The first few are fine, but maybe uncontrolled hypertension, but the arrhythmias and angina pectoris, I don't think it would have really been a problem for me to try that. Monoxide, okay, pregnancy, breastfeeding, I get. The anemia less than 10, I think, is very severe, in my opinion. I don't know, maybe you guys are more strict than, because I come from an ICU background, but I see a lot of patients who are at 8 and 9 and they don't seem to have symptoms, though. And then ongoing radiotherapy and chemotherapy and brain mets seem very, I don't know what.
Yes, yeah, that's it.
it'd be interesting to hear personal experiences with methylphenidate. I have very little.
With Ritalin?
I've experienced with it over the years, and some patients have had and had benefit from it, and I've had some patients who, with the balance between chronic opioid therapy and Ritalin, were able to maintain both work and study, and for some patients where your option is between either lowering the dose because of dose toxicity of drowsiness or poor concentration, or maintaining on the same dose and adding Ritalin, it's often something which is worth a try. And there's also fairly reasonable data about the use of Ritalin for depression. Particularly in the elderly, where you need a very rapid, where you need a rapid response, and you don't have a lot of time to wait for traditional antidepressants.
Okay.
Fallon, did you go through the literature review or in the discussion?
I mean, I read it. I didn't look at the actual studies myself and criticize them, but I did look at them. They look. I mean. When the discussion often puts your own research into the greater context of other research that was done. And did they have any additional comments to make about that? No, I mean, they said that it came out as mixed studies, but when you read them, they look, I mean, I feel like when you have to do so many multi-analysis to get to a moderate benefit, that it's already like weak studies anyways. Yeah. So I wasn't impressed by the back research, and this also I wouldn't consider a very strong study either. So in my opinion, it's something that you can keep in your back pocket. Like you said, if it's someone who has only tiredness and they're having side effects of the opiates, or something else, then it's a good candidates. But I don't know if I would throw it at everybody.
Dear, can I get the screen for a sec?
Yeah, sure.
Yep, all yours.
So I mean, this is just from the ESMO guideline and the section on psychostimulants, and this was published, I think, about a year ago. And it just reviews the data, multiple small open studies. In conclusion, 15 studies showed no superiority with psychostimulants compared to placebo. 4 studies showed less fatigue, and a subgroup analysis suggested benefit of severe fatigue So it remains a subject where there's not, as I said, a definitive, not high level evidence, but it's something which is worthy of a therapeutic trial on an individual patient basis. Mm-hmm. And sometimes a fight with the copain, because this is sometimes to get the Ritalin for this, the pharmacist will ask for 29 tophus 29 gimel.
Okay.
Thanks a lot, Fallon. It was great. Yeah. Next week, Professor Tzaddik volunteered to discuss oral mucositis, which I think we can all benefit from his expertise on the subject. Again, any volunteers over the next coming weeks, we'd be happy to have you on board.
Okay, I will find you another. I'll find another volunteer from here the week after then.
Okay, sounds good.
Okay, everyone have a good afternoon.
Thanks for listening.
Thank you very, very much. That was great.
No problem. It's good seeing you guys. Bye.
Okay. Bye.